Hi, everyone. Welcome to our webinar today. We are thrilled to have Dr. Amy Smith. My name is Suzanne Tomlinson. I'm the Senior Member Services for MNRS. I would like to introduce you all to our presenter now. Dr. Amy Smith is a Buckeye through and through. She earned all of her academic degrees from The Ohio State University with a Bachelor of Arts in Psychology, Master of Social Work with a focus in mental health and developmental disabilities, Master of Science with a certification as a family nurse practitioner, and and it just went away. Hold on. Sorry about that. I was letting someone in. Postmaster certificate as a psychiatric mental health nurse practitioner and Doctor of Nursing practice. She is an assistant professor in the OSU College of Nursing PMHNP graduate program. Her clinical work has focused on serving vulnerable populations in community mental health settings with providing integrated psychiatric care for co-occurring psychiatric and addiction-related disorders. Her past administrative endeavors include the development of opioid overdose response programs, evidence-based program implementation for persons with severe and persistent mental illness, and addiction recovery programs. Most recently, she has trained in integrative psychiatry to expand her ability to provide holistic care and the support of patients on their journey to living meaningful lives with optimal wellness in mind, body, and spirit. Thank you, Dr. Smith. Without further ado, we welcome you.
Thank you so much. I'm very excited to be here today. Like Suzanne said, I am an assistant professor at the Ohio State University College of Nursing and concentrate in the psychiatric nurse practitioner program and training our next generation of nurse practitioners with developing more curriculum and how we can treat co-occurring conditions. In historically, addiction and mental illness have been treated in silos. So very important to move toward an integrated practice where we can treat the whole person in one setting. In terms of how I got where I am now, I really started my nurse practitioner career working with women and their children in a addiction recovery setting, and was very excited about that idea of women and their children coming for treatment and recovery, as it is obviously affects the whole family. So really excited to be here with you today. I have a lot to share with you, so I might talk fast at some points to get through everything, but we'll get started here. See if I can move it forward. There we go. Okay, so our objectives today will be defining recent trends and common characteristics of individuals that are struggling with opioid use, talk about evidence-based guidelines that we're very fortunate to have, national guidelines in the United States as well as the World Health Organization. We're also going to talk about provider barriers and patient barriers to treatment. And then I'm going to discuss alternative routes to treatment versus more traditional routes. And I'm going to highlight, in Central Ohio, how we responded to the opioid epidemic with creating different routes to getting people to treatment. So we'll talk about that. I have no conflicts or disclosures. So overdose deaths. This is not new. We continue to the death rate continues to rise. We are close to losing almost 1 million people since 1999. In 2020, we reached over 91,000 deaths from drug overdoses, which is a 31% increase from 2019. Which, as we all know, the pandemic hit us there in the beginning of 2020 and has been devastating to individuals in recovery. And that being that, there's a high reliance, particularly in early recovery and treatment, on the system, and that we basically closed things down overnight, caused a lot of uncertainty and stress on the population. And then even individuals that are in longer term recovery tended, not having that support, the community, AANA, while people were kind of scrambling and we didn't even have the online environment to support individuals. So a lot of things contributing to that increase. Then last year, 2021, had a 15% increase, reaching over 100,000 individuals. And when we look at the main driver, we're looking at 82% being opioid involved drug overdoses being related to synthetic opioids and predominantly fentanyl and illegal fentanyl. And so opioids are involved in a little over 74% of all drug overdose deaths. So that's about last year, a little over 80,000 individuals dying by opioid overdose, and which that means 220 individuals a day dying, which is like a commercial airliner going down in our country every day. So we lose someone, one person every 7 minutes. So it's had devastating effects, for the individuals, the families, the communities, healthcare. I think all of us have over the years were taken by surprise of this horrible epidemic and continue to figure out what we need to do. There is an increase now with methamphetamine and psychostimulants. And that was actually, we were seeing these introduced through cartel and drug dealers early on, where they would actually give free methamphetamine out when people would purchase heroin or fentanyl. So again, then they're obviously building that profit and clientele to be abusing and using and become addicted to methamphetamine as well. So we'll continue forward here. So with fentanyl, prior to when we look at the heroin epidemic that really started when we transitioned, when cracking down on the prescription and overprescribing that was happening, and that really on a systemic level had put a lot of individuals that may have not needed opioid treatment on it, and then took people immediately off, and people went to the streets for heroin. And then fentanyl. And basically what has happened is there are the drug dealers realize that they could create pressed pills that are counterfeit pills that they could inject fentanyl into to then sell it as if it was a pharmaceutical grade oxycodone. So this has led to overdoses by not only people who are addicted to opioids, but also people that may be trying to relieve pain and they don't want to go to the doctor, because when you ask for pain medicine from a healthcare provider these days, you're treated a lot different than decades past, and for good reason, but also the pendulum tends to swing the other way. So just this looking here, you can see that the press pills are on the left side of the screen, was obviously picked up in a drug bust. And then the right side is the actual pill grade, pharmaceutical grade. So in terms of fentanyl distribution, again, drug dealing 101, bringing this up of why would they do this? Why would they want to do fake press pills versus, just giving them heroin or fentanyl? And it's all about the money. And basically, fentanyl came on the scene really in 2015, 2016, taking everybody by surprise, I felt. And they, they found that they could sell it for a larger amount of money. It's higher potency, so they were making more money. So 1 kilogram going for $40,000 would turn into, 500,000 doses at $20, and they make 10 million off of that. Then if you're looking at, okay, well, oxycodone on the street, a 30 milligram tablet, pharmaceutical grade is about $1 per milligram. So they're looking at 30 milligrams per pill. So drug dealers decided, well, we'll make fake pills, inject it with fentanyl, it's cheaper for them, and then they can make more money, making up to $30 million on a kilogram of fentanyl. So the need for treatment. So there's over 2 million individuals that have opioid use disorders in the United States. And what we do know is people aren't getting the treatment that they need. In 2017, 70% of individuals did not receive the treatment that they needed. And when we move forward to recommendations for medications, which is first-line treatment for opioid use disorder, it's even less. That, as healthcare, we're not providing the evidence-based interventions that are required for individuals to have the most successful outcome. So looking at only 36% of individuals who are seeking treatment are offered at least one medication, and 6% only 6% being offered the 3 medications that are FDA approved. So the real importance that, there's not one route to treatment for any one person. It is that each person has their own journey that they'll have, and medications need to be talked about and available for who needs them and in what circumstances. So, and we'll talk a little bit more about that. I wanted to put this here about the non-Hispanic Black population has the highest rate of overdose deaths. And this looks at 2014 to 2017 in terms of the increase with synthetic opioids of over 818% increase. So, again, we need to also focus on the population and health disparities that exist not only for addiction, but, it's layered on healthcare disparities as a whole. So important to think about. So holistic care needs for individuals with opioid use disorder. So with this, with addiction in general, it is a chronic, progressive, debilitating disease that affects the individual as well as the family and community, and it doesn't happen overnight. In most individuals that I've worked with, there's a high percentage of adverse childhood experiences that this population has experienced at a young age, including physical, emotional, and sexual abuse. And on top of that, living in, toxic environments and having to exist as a young child, surviving that. And then, as they progress into adolescence, the common story is they were offered some sort of substance, alcohol, marijuana, and maybe an opioid. And at that point, they could, numb themselves from the pain, from the suffering that they've experienced as children. And hey, that feels good. I have something outside of myself that can make myself feel better. And what we know about genetic predisposition, as well as environmental and just individualized characteristics of individuals, that their brain responds differently. And once someone is introduced to something like opioids, the substance hijacks the brain, where they're really not able to make decisions or see clearly. And that's where it's very challenging to experience someone and try to understand, why does this person they're willing to give up everything, their children, their home, their livelihood for this substance, and really understanding that the brain is hijacked and they're in this, caught up in this cycle of addiction of, needing to get the substance, getting the substance, then avoiding withdrawal. So just goes to say that this isn't just about removing a substance and removing them from using, but it's about getting to root causes of where the pain and suffering happened before, so helping them to heal. So really understanding that we need a holistic approach for individuals on all levels to help them to recover and heal from substance use disorders. So looking here, it's really important to understand that on this chart here, you'll see on the left side are individuals in yellow that have substance use disorders without mental illness. And on the right, blue area is mental illness without substance use disorders. And then we look at the green area where there's an overlap. And so when we look at somebody who's coming in for addiction treatment, the likelihood, almost 50%, are going to have some sort of mental illness. So the really important part in treating them is that we treat both simultaneously. And, you know, this is what the evidence supports. And historically, there have been different theories and beliefs of, we'll treat the substance and then the mental health will just, you know, resolve on its own. And we know that's not true now. And so what's really important that healthcare providers and practitioners, and what we try to do with up and coming nurse practitioners, is for them to understand that we need to assess and treat both at the same time. So the most common co-occurring mental disorders being anxiety and mood disorders, schizophrenia, bipolar, major depressive disorder, conduct disorder, post-traumatic stress disorder, and ADHD. And so again, looking at that post-traumatic stress disorder, I cannot emphasize this enough of how much, not only again, talking about those adverse childhood events that someone may have had in childhood, but then the whole lifestyle of someone who is using opioids is just defined in itself as dangerous, and they can, you know, assault or rape or other traumatic events are very common. So you've got this person that possibly was traumatized in childhood and then re-traumatized in their use and active addiction. So, and some of them won't meet criteria for PTSD, but they still have trauma-related symptoms that we need to address, even if it's not black and white that they meet this diagnosis. So just being clear that that's something very important to focus on. And I also wanted to talk about ADHD because, you know, very important when we're looking at preventative with our children and adolescents who experience ADHD, that we know that if they're not treated appropriately at a younger age, that then they're more at risk to use substances and have substance use disorders as they continue to grow and develop into adulthood. So really important because, and again, it's when we look at these, how these co-occurring conditions happen, how am I to find relief for my hyperactivity or impulsivity? And if I take this substance, it helps me calm down. This is where we'll hear, like with methamphetamine, that, oh, it calms me down. Well, when somebody tells me, because I always ask, like, why do you use that substance? What does it help with? What is, you know, because there's a reason, right? They're trying to treat or soothe something. So it could be, you know, I'm able to focus, I'm able to concentrate, you know, so then you're just a little more keyed into, okay, what's really going on here? So addiction is a treatable chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. People with addiction use substances or engage in behaviors that become compulsive and often continue despite harmful consequences. So again, a lot of what I've already talked about, you know, the layering of all of the different components that then, you know, present as addiction. And so, you know, that's why the treatment needs to be comprehensive. So here you'll see the National Institute of Drug Abuse in terms of their components of comprehensive drug treatment. And again, really important, you know, and depending on what your setting, you may work in like a community mental health center where you do have more supports and options to help someone, and maybe you don't, maybe you're working in a primary care. So just knowing that these things are important aspects of treatment and doing the best we can with what we have. And we'll talk a little bit more about that as we continue through. So I wanted to share with you the Asam guidelines. These are just a few things. I think it's like 70 some pages, so you're welcome to read through that. But it's very nice just to have guidelines that we have, and it's evidence-based of how we need to be treating this population. And I want to emphasize a couple things on here for practitioners to understand. So first of all, looking at that comprehensive assessment. So as many of you I'm sure know, when you're working with someone who's in active addiction, one of the, particularly to opioids, one of the reasons that they continue to use is to avoid withdrawal. And that's really where they're stuck in, right? And there is such a fear and anticipation that when you have someone coming into treatment for help, they're in such a state of distress that, I mean, I know as a provider, I almost become distressed because my urgency to help them and get them, the medication that they need that I know is going to relieve them their withdrawal symptoms. And so understanding as the guidelines are, we need to perform an assessment. We need to get through that, but we don't have to get every single little thing from assessment the first time we meet someone. We need to get those essentials in order to start the medication so that we can stabilize them, right? And then we have plenty of time the next time we see them and further on in the treatment process to get those tidbits of information of maybe what was their childhood like, and how many individuals in their family have mental health issues. Those are important questions, but do we need them right now when someone's in distress? No. And the guidelines are saying that we don't need to delay medication treatment just to get all of those assessment components. So I think that's really important to understand. So they want, obviously, all the FDA approved medications to be available. They also emphasize how buprenorphine and naltrexone can be prescribed in all settings, and the waiver is required for only the buprenorphine. Using methadone and buprenorphine for withdrawal management is recommended over cessation of opioids. So that's really important for people to understand, is that these medications are recommended for withdrawal versus just letting someone go through it. And this and what the evidence is telling us is that typically most people are going to need this medication at least for some period of time. That we've tried in the recent past, different programs will try to do a fast taper. So let's say put someone on buprenorphine or Suboxone, inpatient, and then they say, okay, we're going to give you a taper for the next week, 2 weeks, and then you'll be off of it. Okay. Well, if individuals with opioid use disorders were able to do that, they would do that themselves, right? So one of the reasons why medications are really important is because it stabilizes the brain chemistry and manages the withdrawal. So then we're working on those behavioral and lifestyle changes, as well as addressing other mental health concerns, building coping skills, building supports, and then down the road, talking about tapering if that is something that somebody wants to do. Another important piece for providers to know is that office-based and home-based initiation of the medication are considered safe and effective. So sometimes one of the concerns for prescribers may be that buprenorphine is an opioid. It can be used on the street, which typically it's used to avoid withdrawal symptoms. People are not, for the most part, getting high on buprenorphine. They're using it because they can't find fentanyl or heroin or some other opioid to relieve those symptoms. So understanding that's a concern, but also that we shouldn't be fearful of talking with the individual about starting this medication at home. And again, you're limiting them. Hey, we give you a couple doses, we'll see you tomorrow, those type of things. And really talking with the person about how to do a home induction. And for the most part, again, most individuals that I've worked with at least have used buprenorphine on the street at one point or another. So they understand, and some of them will say they've put themselves into precipitated withdrawal if they took the medication too early. So there's an understanding that that's one of their biggest fears, so they don't want to go through that. So, talking with them about using a tool like a SOWS to figure out where they are withdrawal to start that medication is okay to do and completely safe and shown to be effective. And then another important part again is with prescribers prescribing the correct dosage. So, and seeing this happen where, they want to keep someone at 2 milligrams or 4 milligrams because that feels better to them as a prescriber for whatever reason than going up to the typical 8 or 8 to 16 milligrams a day. And so the guidelines, again, letting us know that it's very important that we get people to a safe and effective dose, or else we're not really helping them if they're kind of in withdrawal here and there because their dose isn't high enough. Okay, so that's a really important component as well. And then when we're discontinuing buprenorphine, it's really going to require a taper over a long period of time, sometimes months, sometimes longer. And again, just noting that there is no timeline, that ASAM is saying that some individuals will stay on this medication shorter term, some will be on long-term or lifelong. And again, it depends on the person. You know, if it's someone who has a 30-year opioid addiction and has tried treatment 3 or 4 times and has chronic back pain, you know, maybe they need to be on methadone or buprenorphine long term. So, and that's okay. So these are our 3 FDA approved medications. So looking at the buprenorphine is a partial opioid agonist, methadone is a full opioid agonist, and then naltrexone, which is a long-acting form that's recommended for opioid use disorder, is Vivitrol, and that's a blocker. So when we're looking at someone who's an active opioid addiction, we and they want to transition to medication, really our primary considerations are going to be the buprenorphine and methadone, and buprenorphine, being that we can use that in most settings, is that going to be the primary that we're looking at, where someone can go from using opioids one day or fentanyl, and then, you know, they can stabilize on the medication within a day, 2 days, and then engage into treatment. Naltrexone, although very helpful to reduce relapse, there needs to be a period of time where the person is completely opioid free. And that can become a struggle for individuals, particularly like if people could just stop using, they would, right? And they wouldn't even need treatment. But that's where it's so powerful with not only the withdrawal symptoms, but also the cues and triggers that someone is living in. Although I've tried with many individuals, like to help with comfort medications and let's try to get through this, that to not have an opioid at all for 7 to 10 days, to start the naltrexone, it can be a challenge for people. So, but again, that can be helpful, and that's where it's very individualized, and we need to be using precision medicine to help people get to whatever treatment best fits them. I want to also just mention that the Comprehensive Addiction and Recovery Act of 2016 is when nurse practitioners were given the opportunity to prescribe this medicine. And if you look, that we've had some significant gains from 2017 and 2018 and beyond, because, you know, we have more providers that are on the front lines that can prescribe this. So my hope is that I'll give some ideas for hopefully some practitioners and where they are, where they may be able to help out with our cause. Okay, so looking at provider barriers. So stigma is probably one of the worst. Well, actually, addiction is, I mean, people stigmatize people with addiction more than people with mental illness, which we already know is pretty bad. So as providers, it's really important that we look at ourselves and our own bias, implicit, explicit, and that we can see, you know, work through those situations and issues and thoughts and feelings and judgments, because we need to be able to provide the best care, the evidence-based care that people need. So I've seen this throughout my career in terms of this stigma. And, you know, when we look at healthcare providers, just in general, it has turned off a lot of individuals wanting treatment to seek treatment, because they will be treated in such a way if they ask for help from their primary care, or maybe going into the emergency department, which I think we're getting better, but we still have a long way to go. So really put it back on the provider to explore and dispel some of the different myths and misunderstandings that they have about people with substance use disorders, that they lack, that there's a lack, or there's not a need for it or demand. And this happens, I think, a lot with not even asking the questions. And we even see this in psychiatry where, it's so focused on treating the mental health that we're not even really asking about, do you use marijuana? Do you use, this and that? And whether that's just being left out, or is it, well, that opens up a whole nother can of worms that I'm going to have to deal with, so we need to get better at screening. And not even just screening at the beginning, because again, the relationship and the provider-patient relationship, you have to build trust to be able to say something to someone that, hey, I need help with this, right? And this is more true with substance use and alcohol use, because people feel that judgment. So a lot of times, even if you did a screening like a DAS or an audit at the beginning of their primary care or their behavioral health treatment, those aren't accurate, right? So maybe it's the third or fourth interaction that then you've built that rapport that they feel like I can come to this person and say something about my struggles. So knowledge, and again, we're trying to improve that, particularly in academia and programs where we're I know in the program I teach in, we require them to do the waiver training during their training and their they're in clinical placements, they're doing the waiver training, and then once they get their certification and their DEA, then they're off to the races. They're able to step up and help out. Time constraints can be an issue. Insurance, I know in Ohio, we have a wonderful advantage of Medicaid expansion that we've had for years now, which made a huge difference for people who are struggling because it is income based, that they can get the resources and the treatment and the medication that they need. So there's a few more through there you can look at. Then a patient identified barriers to treatment. So again, back to the social stigma, the self stigma, the shame and blame that people have towards themselves. Have their experience with buprenorphine, again, like I mentioned, it may be used on the street and people say, well, I don't want to use that because it's just trading one addiction for another, which is absolutely not true. When somebody is in active addiction, their life is in complete chaos, right? Their only reason is to seek out in severe addiction, to seek out that drug, to have that drug, and then it's a continuous cycle every day. Well, when someone's put on a medication like buprenorphine, they're no longer living like that. They can engage in life. They're not racing after this medication every day. It's not that. It's just a medication you take, stabilizes everything, and you can engage in your life. So it's very different. And we need to dispel some of those beliefs that providers as well as patients may have. So again, the lack of knowledge, I think we saw that. So when I started practice a decade ago, treatment was very siloed, not only with the addiction and mental health, but also just like inpatient and outpatient. Nobody really collaborated with each other. Nobody was like, hey, maybe they'd be a better fit for your program than my program because we require XYZ and you don't require that. And you'll see that in treatment, there's going to be different places that have more of a harm reduction approach than maybe a more abstinence-based approach. So knowing those resources in the community and in your community is important to get people where they need. So a lot of the patients were, they didn't really know where to go other than, back years ago, it was like they called a number at 8 o'clock every morning and was put on a wait list. Okay. And the structure was, well, you're on the wait list and you have to call every morning at 8 o'clock to see if your time has come up. Okay. And for someone who's in active addiction, are they even going to call that morning? And if they miss a morning, you're off the wait list. And so that is not very fitting for this population and their needs. And in many situations, we'll talk about this, there is a window of opportunity that somebody may be ready, and it may only last a few minutes or maybe a few hours. So if we lose that person when they're at that place of readiness, we won't find them again, or we can't locate them again. If we say, oh, you're ready today, well, we have an appointment in a week and a half. Can you show up for that? well, then they're back out there and, they're not showing up to that appointment. So a lot of the things that we've needed to do is to restructure ourselves as healthcare providers and how we're allowing people to get into treatment. Okay, so we're going to talk about the traditional versus the non-traditional entry into medication for opioid use disorders programs. And so when we look at a traditional entry, we're just looking, typically it's a patient is requesting and initiate treatment, either an outpatient or inpatient. Okay, so that was basically how we were before. And, as we started working, back in 2013, when I was first involved in the field, that, like I was explaining, that wait list, or, we take the first 2 that come to the door and everybody else can't come because we don't have assessment times for that, So a lot of these things create real issues for people to access treatment. So as we worked together, and I'm just going to be highlighting, Central Ohio and the community response that we've done here, and I've been a part of. And it's different all over the United States. And that was one of the things I think as, healthcare providers and emergency response, first responders, schools, families, all of us were just kind of taken by surprise with all of this. And, as people were dying, as, a whole community was dealing with this epidemic, I think is when we started to reaching out to each other and partnering. And I can tell you that one of the first things, it was back in 2014, the first time I said to law enforcement, I want to come out on the street with you. I want to, because you see the people out there, and you're able to intercept. And if we could find a way to intercept people in the community before they're knocking down our doors, because they want treatment, and letting them know that treatment's here. Now, I developed a lot since then. I was pretty naive going into that. I remember the first outreach we did in 2014. It was women soliciting on the west side of Columbus. And I went out and I basically was like, hey, we're here to help change your life, come into treatment. And I was pretty traumatized personally by just what I saw the women living in and what they were experiencing. And they were very angry with me. I mean, they were angry because they were being arrested. But I was like, well, you can have treatment. We'll get treatment. I got phone numbers for family members. And that's when I started working with the court system. We have drug courts and specialty dockets here, including like Catch Court, which was a human trafficking court, which would work with these women that were picked up to try to get them into treatment that way. Well, they had 28 women that day and 0 came into treatment. So the next year, 2015, went out, and I was also working at a federally qualifying health center, and decided to try the approach of, I'm a primary care provider. Come in and see me for anything, so I can do your women's health, I can do your mental health, you can do, you have an abscess, whatever it is. And that response, 50%, and it was the same amount of women, all had opioid use disorder, probably some methamphetamine use disorder as well. 50% of the women came in and established for primary care. And so that was like an aha moment for me. I was like, okay. So, and again, we know the theoretical stages of change, right? I can't force someone to go into treatment, but hey, I could be a provider that when they are ready, they know I can go talk to my primary care and they're going to get me into treatment. Okay. So, and then that led into, again, like law enforcement really understanding, because I think they didn't really understand that there was like a disease process driving this. I think they thought, at least the ones I worked with, like people were just doing this because they were doing this, like wanted to commit crimes or solicit, or, and them really having that like, oh, like, no, there's like, this is called like substance induced crime, right? Or criminal behavior, is that there is an underlying driver of substance use. So that's when we really started to work together and talk about, how could we build a program And this was as overdoses, particularly with heroin. We hadn't even seen fentanyl, it didn't even come on yet. How can we do some outreach? And that's when we developed the overdose response program. So I'll talk about that more in a minute. Other non-traditional routes of entry, would be through EMS, emergency room, addiction stabilization centers, hospital emergency departments, doing buprenorphine, hospital addiction consult teams, community and public health outreach, criminal justice system, and then primary care. And we'll also talk about mobile units. So this here, a community response to the opioid epidemic. This looks at our Franklin County Opioid Action Plan. This was really put in, I think it was 2017. And I just wanted to show you, how many people came to the table, because, we had some things already going in the community, but we needed to do more, and we all needed to do this together. This was not something that, again, we could work in our own little silos and find a solution. So, lots of committee meetings, lots of recommendations, and, and we continue to work on these things to this day. So like I mentioned, so the HOPE Task Force, and I have the trade here. I don't know if any of you have seen it, but it does highlight the HOPE Task Force. It was a Showtime documentary that really looked at how the opioid epidemic and everything was being affecting the United States. And so if you haven't seen it, it's an interesting documentary. So this was pairing with law enforcement after overdoses. And so with like a non-fatal overdose, we typically would go out the next day at the location of the overdose and try to engage that person. Again, we're talking about if they want to go to treatment, if not, hey, do you want to go see a primary care provider? So, wherever we could engage them in whatever services that they were willing to, even, a syringe exchange, and definitely naloxone. Naloxone, we've done a lot better as a community, get it out. Individuals struggling have it, families have it, professionals have it. I think that's one public health initiative we've done really well at. So with law enforcement, one component that they were very focused on while we're trying to get people, into treatment or into services, however we can, they're trying to figure out where this fatal supply is, right? Because if we have a batch of fentanyl that's taking people out, can we locate it and take care of that supply so people aren't dying? And, it was an interesting lesson that we learned was at one point they put a public statement out that there was fentanyl, lethal, and actually people ran to it, and it was very scary for everyone. Like, okay, well, we need to be careful, because again, when you're looking at the addicted brain, they're seeking out that, the highest potency. So we learned from that. So with the law enforcement outreach, what we found is that we couldn't find people the next day. And so that's when we went on to develop, and this was in 2016, a rapid response team that would then work with EMS dispatch, to meet individuals at the emergency departments, to engage with them. And again, if they were ready to go to treatment, we already had that relationship with the Addiction Stabilization Center. They could go straight there. If they didn't want that, they could go to an outpatient treatment for buprenorphine if they preferred that. And we had obviously a lot better success because we were meeting them right there. And it also helped with the EDs to take some of that pressure, where they aren't used to dealing with this type of with addiction and mental health. And so it was, I think, it was a relief for them to have that support there. And so in terms of our statistics that we had, it seemed that we were able to engage with about 55% of individuals that came in. We linked about 44% of those individuals to services. And that was about 47% went to detox, 27% went to MAT services. And I was initiating that from a primary care setting. And then we would link them with outpatient treatment. So get them started on the medication, and then they'd have enough medicine to get to that outpatient medication and treatment that they needed. And then about 26% came in for primary care services. So again, that harm reduction. So hospital emergency departments, our OSU emergency department started, they had the overdose response team, but they also started, and I think it was 2018, started people on buprenorphine and had peer support that would then connect them to an outpatient where they would continue treatment. And again, that bridge prescription, so starting the medication, you have an appointment in 7 days. I'm going to give you that amount of medication for you to get to that facility. And that was, and it's worked really well. And, it's a lot of emergency departments have, some hesitation about this, but again, OSU did it, and they had actually gotten the model from somewhere else in the United States. So again, we all kind of learn from each other and the different programs and approaches. The hospital addiction medicine consultation liaison service. So this was like when people were in on a medical floor, they may have opioid addiction and they're not treated. And so a lot of times providers might do pain medication for them through their stay and then they leave, right? Where these teams, this consult can actually engage them into services, start them on buprenorphine, and then link them to outside providers. I mentioned the Addiction Stabilization Center. When this opened up, this was a dream for us, and it mostly focused on overdose response, and then moved on to people could walk in. So having a place 24/7 that if you were struggling and you wanted treatment, you could walk in. So that's where that access, we need to immediate response when somebody's ready. So having that, and then the community referral network was basically where, the overdose teams or the stabilization center would then refer out to other programs that best fit that client or patient. There may be someone, even though we're suggesting residential care, they're like, no way am I doing residential care. Okay, well, let's think of an outpatient. What are you willing to do? And work with people from that perspective. The criminal justice program, so another route to treatment. So I was part of the first in the Franklin County jail of starting people on naltrexone or Vivitrol. And now this is, they use it all the time, which is wonderful. And I know there's programs across the United States, but unfortunately, when somebody comes into a jail, they're going to be, they go into withdrawal and they suffer, right? Because in most jails, they're not going to be treating people's withdrawal. Well, if they're there for, over 7 to 10 days, the opioids are out of their system. Well, this is a window of opportunity that we can get this person on a blocker and get them, start their recovery as they move out. Again, it's a way to intercept and intervene with the addictive process and the cycle. No one's happy to be in jail, but could we take this opportunity to, see clearly and move toward recovery? So one caution with that is what we did find is that some people would say they want the shot just to get out of jail, because there's obviously that motivation. And the concern with that is that the Vivitrol can be overpowered, particularly with fentanyl. And, before fentanyl was an issue, that wasn't such a big problem, but now that they could overpower and actually overdose. So we want to make sure that that person is really motivated. And then there's some literature as well on buprenorphine treatment, on pre and post release incarcerations, and showing that engagement's better and that they stay in treatment longer. Also talked about incarceration status. So again, that prejudice of, oh, this person has been in prison, so I'm not going to put them on this medicine. There is no valid evidence for that. And so what they compared is if somebody had an incarceration versus no incarceration status, that they still are going to have comparable outcomes. And then there was no influence on rearrest or reincarceration. So again, looking at it through the lens of substance-induced criminal behavior versus the person. And then looking at this Connecticut community health caravan. So this was a syringe exchange. That was the first mobile induction and maintenance program, and that was with buprenorphine. So this was something new I learned while I was putting this presentation together. So really neat to see, because we do have, geographic location can be a huge barrier for people. So a mobile clinic being able to bring medication and services to people is wonderful. And then lastly, I wanted to talk about the primary care office-based opioid treatment. And that was something we used with the overdose programs to get people on. And just want to emphasize that primary care is on the front line for mental health overall. And so the more we can, that primary care can help out with the buprenorphine and getting people started and getting them connected, or even having their own counselor within their clinic can be really helpful. I think, I worked in a primary care, and then I've worked in a behavioral health model with scheduling, usually someone's scheduled for that certain amount of time, where with primary care, we double, triple book, people don't show up, somebody walks in, we work them in, those type of things. So that flexibility can be really helpful with treating people with opioid use disorder. And then ending with, why is addiction treatment evaluated differently? Both require ongoing care. So when we're looking on the left with hypertension treatment, prior to treatment, within treatment, we have symptoms go down, and then, post-treatment, there's relapse. And so addiction is no different. It is a chronic condition that people need support throughout. There's going to be times of hardship. There's going to be stressors that people may lapse or relapse, and we need to be prepared, or even preparing them to avoid those situations. So close to even hypertension and asthma relapse, addiction is at 50 to 60%. Hypertension and asthma is around 50, I think even 60 to 70% relapse. So we need to start looking at addiction through the same lens and as we approach individuals. So that's it. We talked about a person struggling and how it's complex. We need a comprehensive treatment approach, that we need to break down barriers to improve access and successful outcomes, considering non-traditional programs and a community-wide approach is the most helpful. And the use of medications is recommended. It's what guidelines say, and that we need to start to work together and work as providers to, make sure that we have these evidence-based practices available to every individual. And that's it. Sorry, I went so fast. It's a lot of information. So does anyone have any questions?
Please feel free to turn your cameras on and unmute yourself if you have any questions. Thank you, Dr. Smith. That was wonderful.
Oh, sure. I know it's a lot to digest.
And she has granted us the opportunity. I will send around her slides after this afternoon.
Wonderful.
You're getting some comments in the chats of thank yous.
Oh, good. Thank you for attending and spending this time.
There's a question in the chat from John. When the evidence changes, how are new treatments developed?
So when the evidence changes, so being that, when new medications come out, and how does that impact the treatment? And I think with everything else, when we look at research and we look at evidence, it takes a while to translate or transition to be applied in practice. So I think it takes the organization being up to date and knowing what guidelines are saying and knowing what research to make those changes. And I think with the opioid use epidemic, people are definitely much more on top of this because we're talking about it constantly. We've got so many individuals in this together. So I think that helps with sharing the evidence. So yeah, I don't know if that answered, but yeah, it can take some time. And like I was saying, when I started in addiction treatment, some of the philosophies were very different, and people felt very strongly against any type of medication. So again, it really depends on the leadership and the staff, and if they're willing to adopt these the new evidence to move forward. And it's like any other behavior change, it's hard, it's difficult for people to do. So thank you for your question, Jen.
Okay, so I don't suppose any more questions are going to come in. We can go ahead and end if we'd like. Thank you so much, Amy.
Yeah.
And we look forward to seeing you again in the MNRS community.
Yeah, well, thank you for having me. I appreciate your time.
Absolutely. Have a great day, everyone. Bye.
Bye.
Bye.